if there are no questions, you'll be forced to speak to each other. So I think you may want to have questions, at least for Dr. Joe and some of the other people. All right. I see a hand up on the left here. Michael is coming to you with mic number 2.
Oh.
Yeah. There you go.
I'm a little mixed up on something, so I have a 3-part question that may help me get unmixed up on something. The first part is the standard of care today 3 drugs together or 4 drugs together? Do different doctors have a different standard of care? Some doctors believe the standard of care is 3 drugs together, and others believe the standard of care is 4 drugs together. And some of the doctors, even in the same institutions, believe that the standard of care is 3 drugs, and other doctors who have spoken here today, I think who are part of that institution, believe that the standard of care is 4 drugs. So if you can clarify, when doctors think about the standard of care for a patient, I'm newly diagnosed multiple myeloma patient, and I moved from MGOS through smoldering to active standard myeloma in like 45 days. So I was just, since I'm on a 3-drug treatment, and my doctor told me that's the standard of care, but now I hear 4 drugs is a standard of care, and I've only was diagnosed within earlier this month or late last month with active multiple myeloma.
So first of all, thank you for your question, and thank you for being here, especially this soon into your diagnosis. I hope you're, thank you. I hope you're feeling the support that you need and getting the information that you need, and we'll be more than happy to spend some time with you later on during the break as well. So the word standard of care is challenging because there isn't some perfect, ideal, everyone is cut with the same cookie cutter, because myeloma is complicated and myeloma is a little bit different in each patient. When I made reference to the fact that we're sort of moving from 3 drugs to 4 drugs or from triplets to quadruplets, we're seeing that in general that 4 does work better than 3, but lots of caveats come with that. Caveat number 1, it takes a long time for that transition to happen. So even though a clinical trial shows it, it takes a while for that. Then the company that did it submits it to the FDA reviews it, it gets approved. So for example, in patients not going to stem cell transplant, those 4 drug trials are under review. They've not been, if you will, approved in that way. So it'd be very fair for someone to say it's not really the standard of care yet, because although the evidence is mounting, it has to go through formal review to ensure that's a standard of care. What makes it also a little bit complicated here in the US is it's, in a lot of countries, a drug gets approved or not, and it's available or not. Here in the US, it's a little bit different, that even before the FDA approves, let's say a 4-drug combination, if a group of experts get together and add it to what we call the NCCN, or the Cancer Comprehensive Network guidelines, then insurance companies will reimburse it. So we've actually had quadruplets for patients who are eligible for transplant for a couple of years now on the NCCN, but the approval from the FDA was much more recent. So that's a long-winded way of me saying it's actually very rational that some would say 3 is the standard, others would say no, 4 is becoming the standard. The other caveat that's really important is it's got to be applied to the individual. I don't just tell every patient that's newly diagnosed, as I said before, you'll take it and you'll like it. Like, these are the 4 drugs and I'm giving them to you. We have to match that to the patient's other medical issues and comorbidities and desires and interests, like Teresa shared with us, and shared decision making. And some patients may still only get 2 drugs. Some may get 3, some may get 4. So it really depends on the exact scenario, because it's very hard for us. especially in disease like myeloma, to just say everybody gets exactly this. You know, I'm not trying to make light of it, but it's like asking 10, Michelin-rated chefs, how do you cook a steak? You know, and they're going to have 10 different ways of doing it. There'd be subtle differences. There'd be some central pieces to each of them. And so there is that subjectivity in the treatment. And so that's why it's hard for me to just say it's go or no go. Lastly, I think the idea of using 4 drugs in a patient who's not planning to go to transplant is a hot topic. That's why I mentioned it as a hot topic, but it's not really considered the standard of care yet. We still need to learn how to apply it a little bit better. It's more so for those patients who are going to transplant. I hope that answers your question.
Yeah, since I also have the mic, I want to add a couple of things. One is the need to have a myeloma expert as part of your treatment team. And then choosing the right myeloma expert for you. There are myeloma experts who say, in our institution, this is how we treat myeloma patients. You want someone, a myeloma expert, in my opinion, who only treats myeloma, or they live, breathe myeloma, to be able to be part of your treatment team, if not directing your treatment team. I think the second one is this person, in my opinion, needs to have the clout and needs to be high up in their institution, in some cases to have the ability to override what others may say in our institution, this is what we are doing. In spite of everything that we talked about clinical trials, don't forget that you are an individual and you are unique.
The only other thing that I would add to that, mainly because you're so recent with your diagnosis, and the ESA VRD combination is not formally FDA approved. And this is something that I've seen over the last couple of years as we've heard about quad therapies and should we or shouldn't we until the data really came out, is the doctors oftentimes were waiting on some of the or the bone marrow results, the FISH studies, and would reserve that quad concept for people who are demonstrating high-risk features within the bone marrow test results. And so it may still be a consideration that your doctor is thinking of, and by all means, you should be bringing this conversation to that doctor, but it may be something that's still in the works, considering that option based on those FISH results if they haven't come back yet. I'll just throw that little bit in.
Okay, number 2 and then number 1.
I was wondering, what is the difference between a patient that's on their way to bone marrow transplant and one that's not?
Yeah, that's a great question. Again, a question that will have multiple answers depending on who's asking it. But the concept that I shared earlier in the 101 session was that historically we've felt that transplant, or that big whopping dose of treatment that I described, is of benefit to myeloma patients. But we know that it can be really harsh on certain individuals. Historically, we kind of had more of a simple age cutoff. And frankly, in most countries in the world, there is an age cutoff, and that age is often 65. So in most countries on this planet, if you're 65 or over, you are not eligible for transplant, period. That's why they do a lot of these clinical trials with patients that are, in the 2 trials that I mentioned, the IMROZ study and the benefit study, where patients were so-called ineligible for transplant. Those patients were pretty much all between 65 and 79. They had a cutoff of 80. Here in the US, we've been a bit more flexible. We've said, look, we have a lot of patients in their mid and late 60s who are still very fit, very active, who could tolerate the procedure. So what differentiates them, this eligibility, is not easily defined, but is a process of evaluating someone as to whether or not they're healthy or fit enough to go through it, because the process is quite difficult. You end up, you become immune compromised for several days. You can get quite sick with it. So in general, if someone is under 65, they're usually eligible. If they're over 75, they're usually not eligible. Where that assessment of someone's fitness becomes really important is between 65 and 75. And again, some centers are very transplant aggressive and they want to transplant as many people as they can up to that age or around it, and others are a little bit more, hey, we've done really well without transplant in a lot of patients, so maybe we don't need it. But that's usually what makes the decision. And it comes back, as we said so many times today, to a conversation with their doctor. Do I want to transplant, or maybe do I want to collect my stem cells for transplant and not have it right now and defer it or delay it for later? That's also a third option. Right. So a great question. So if you didn't hear the question is why would you then give 4 drugs to someone who is going to transplant and 3 who's not? It feels like they're getting even less therapy. Historically, those patients not going to transplant obviously are older and more frail, and we didn't think they could handle 3 drugs, let alone 4. But now, as we've come to use these drugs more effectively and more carefully, we've learned that with lower doses and the right strategies, we can give more to them. So the idea was not to try to deprive those people who are not eligible for transplant, but was to make sure that we're not over-treating them, right? Our greatest adage in medicine is above all do no harm. And so I want to be careful. I have a 86-year-old individual who's frail and weak. I'm not going to give them 4 different chemotherapies together. That may be very inappropriate to do. So it's a question of matching the treatment to the patient.
We're treating a person with myeloma, not myeloma.
Anyway.
Yeah.
Number 1.
So Dr. Joe, I'm interested about the community physician component to clinical trials, and specifically, I guess kind of 2 questions here. The first is, how do you find most community physicians are alerted or educated on the ability or eligibility of clinical trials currently? Does it come from pharmaceutical networks? Does it come from things like ASCO or ASH? And then secondly, how does the IMF or patients like us become also more engaged with them in terms of potentially informing them or educating them about the potential for clinical trials?
Yeah, I can start. Maybe Yelik, you can wrap up with the second question. So first question was really, how do docs know about clinical trials? And you summarize some of them, and I think it really depends regionally where they are, is that in a disease like myeloma, where the majority of patients are still treated by a community oncologist who spends the vast majority of their time in solid tumors, they have their go-to person for myeloma, right? So I joked earlier about my phone ringing all the time. I'm the go-to person for a lot of community oncologists in the Phoenix area, and we have a lot of community oncologists there. And so they learn about what's available through their go-to person or their go-to institution. And one of the things we've strongly encouraged, like for example, my institution, we send out an email every 2 weeks with a listing of all of our trials in very simple, sort of digestible bits instead of the whole long description to anyone who's ever referred a patient to us through an email. And so that's how that network grows. We think that's something we can leverage and do even better. And then you're right, when people go to these medical meetings and so on, they're aware of CAR T-cell therapy. So before CAR T-cell therapy got approved or bispecific antibodies got approved, they were aware that those modalities were under investigation and were under clinical trial. And so now we're telling them, look, we have a whole new wave of bispecifics and a whole new wave of CAR Ts that are being developed. These patients can come on those trials as well. In terms of the IMF's approach to it, I'll let Yelik answer even a little bit more, but I think our audience as the IMF has historically been a patient population and a myeloma doctor population, as well as our advanced care providers, in particular through the Nurse Leadership Board. I really see us moving in a direction where we're, in addition to that, really trying to be a stronger voice to the general oncology community. Because myeloma's become so complicated, because there's so much that a community oncologist who treats breast, colon, lung, they treat 40 tumor types, they can't keep up on anything. We want to be a greater resource to them. And even things like the Spark Cures program that Yelik is describing, I think will be a great resource to them.
Yeah, absolutely, Dr. Joe. I think there are 2 aspects of your question as well, Kent. One is, how do the community physician know about it and send their patients to a clinical trial or refer them to a clinical trial? But don't forget, there's also a fear of losing the patient to a center of excellence if that patient is referred and doesn't come back. So I think there needs to be some level of trust that is established between the community physicians and the centers of excellences, where if I refer you for CAR T or BCMA therapy to the centers of excellences, you will get your first few doses, and you will come for your maintenance dose or whatever it is in your community physician. So I think there are opportunities for us to educate and also advocate on behalf of myeloma patients and on behalf of whoever is doing reimbursements for these community physicians as well. So there is the bottoms up, educating the patients so they can actually advocate for themselves and go to the doctor and say, these are the clinical trials that I want to participate in. There is the angle of us empowering the community physicians and the patients through a digital technology and allowing them to bring that knowledge to the community physician. But there's also that additional level of trust that needs to be established between the community physician and the centers of excellences.
And I would just add to that the role of the patient advocate in things like ECOG and NCI and these places where the clinical trials are being developed, we need to make change in what those concepts and protocols become so that we can start a therapy at an academic center and transition into the community so that there can be a seamless stream of care and still allow people to participate in clinical trials. So the role of advocacy is really big in this particular topic.
Yeah, number 2 over there.
Hi, Dr. Joe, I have a couple of questions about the understanding of the labs. So my husband been diagnosed 7 years ago, and we've been doing all the standard, IgG, IgA, lambda kappa ratio, and so on and so forth. And then recently he started on Tikvali, and all of a sudden his kappa and lambda says they're undetectable. So like at some point it just goes away and it's no longer a marker, or how does that work? Because when I saw it undetectable, I was all alarmed. But the doctor doesn't seem to care. And the other question about the bone marrow autopsy, is there a rule of how often that needs to happen? It only happened once at the very diagnosis for us. But the way you were talking about it, it seemed like it's something that happens somewhat regularly.
So 2 great questions, and I'll be brief in my answer because I know time's going quickly. So one, we are learning with a lot of our newer treatments now that the normal levels of our regular immunoglobulins, so we all have some of the IgG, the IgA, IgM as you mentioned, and we all have some of those light chains, right, that Teresa and I showed on that original picture. So whether you're here and you have myeloma or not, we all have some that should be circulating in our body. When we treat myeloma, often we try to get rid of the bad ones, but there's some friendly fire, and we hit the good ones too. We sometimes call that hypogammaglobulinemia, or people get a low immunoglobulin level. Some of you have already talked to me at the break. I know some of you are getting replacement immunoglobulin, what we call IVIG, or intravenous immunoglobulin, because you're higher risk of infection by not having that. Some of these new therapies that we're using are particularly powerful in that. That's why I started the hot topic, where the third hot topic was less is more, because I think we're actually probably over-treating some of these patients. And what's happening, like you described with your husband, where the kappa on the lambda level disappears, that could be too low, because that may be reflective of his immune system. But I don't think it's because your doctor doesn't care. They're happy that it's not high, right? Because it's telling us that, okay, maybe we've wiped out some of the good, but it also means we've wiped out the bad. So that's something we need to monitor. Your second question was bone marrows, how frequently. I'm not a big fan of putting a needle in someone's butt unless they need it, right? I'm just being, very blunt here with you. That there isn't a strategy where we say everyone needs a bone marrow every year or every 2 years. Sometimes in certain protocols or institutions where they're collecting information, they do it more regularly. But typically we do the bone marrow test to originally make the diagnosis. If someone has a bone marrow transplant or a stem cell transplant, we typically do one somewhere around day 100 afterwards as sort of a convention to see what the marrow's like after a transplant. transplant. And then we may consider doing a marrow at any point when someone relapses. Because people can go from standard risk to high risk myeloma, and the only way we can know that is by doing the cytogenetics, and the only way we can do cytogenetics is by doing a marrow. So it's not something we may do as regularly as blood tests or even as scans, but we don't have a formal, thou shalt have a marrow every year or every 2 year concept.
My question is about two steroids, at least I think the second one is a steroid. So I've been on Velcade for 7 months and a very low dose.
Sorry, can you move the mic right to your mouth? It's hard to hear you. I'm sorry.
I've been on Velcade for 7 months, just one, how is it measured? 1 milligram. And right away I developed styes that don't dissipate. They don't go away. They get better, but they stay on my eyes. With the first one, my doctor prescribed an antibiotic. Didn't seem to help, and I can't live on antibiotics. So it's worrisome for me, and now I'm going to begin maintenance on Monday. And instead of 1 milligram, he's going to up it to 1.3. So I'm concerned about styes. I'm wondering why you think people develop styes when they're on Velcade and some don't. I don't think it's because my immune system is low, because it's not, but they're just there. And I mean, it interferes with the eyelashes are missing permanently. So that's my first question about Velcade. And then I'm going to start Medrol every other day, starting this Monday. And I'm worried about that also because friends have told me that you can develop the moon face. And I'm wondering what your thoughts are on those two drugs and why.
You want to start, Teresa?
Yeah.
Well,
Styes
with the styes, first of all, we know that with some of the newer therapies that, like the belamaf or belantamab mafodotin, that people have experienced ocular toxicity, and we're aware of that, but it's not very common with Velcade. Actually, I've only heard of it a couple of times with Velcade. But there can be some infection-related irritation of the eyelid, and sort of makeup related, making sure you're getting rid of all old makeup and putting on new, maybe taking a holiday from it. But my first question, I guess, would be, has an ophthalmologist been involved or a dermatologist been involved to really take a look at what might be the true source? Is it truly Velcade or is it infection-based?
Yeah, I think the other thing I might add to that is, I've had a few patients in my practice. If you're getting styes, and again, the caveat always is I am a medical professional, but I'm not sort of serving in that role here. Yeah. Obviously discussion to have with your physician. It's hard to be very specific. But I have had about a half a dozen patients over my career who just have recurrent, serious styes with Velcade, exactly what you're describing. And honestly, the only way to stop it is to switch from Velcade to something else. The mechanism is not fully understood. I think it's a good idea, get dermatology involved. I like teasing my colleagues, to have a look. Again, I'm not trying to make light of it, but who they have some idea. There's some, symptomatic things that they can do. But ultimately, if they keep coming back, in my experience, in the few patients I've had, but I've discussed this with lots of other doctors, because this comes up about once every 20 patient family seminars. The only way to really get rid of it is to stop, unfortunately. So typically we'd have to look at what other options there may be if it's affecting your lifestyle as much as it sounds like it is. Because as Teresa said, I don't treat myeloma, we treat people. So we have to be really careful with that. I assume that they're talking about Solumedrol, like on a steroid that they're going to give you every other day. And there's different strategies for steroids. Typically, we've talked about dexamethasone so far, which is typically a once weekly thing, because we think of dexamethasone being so-called a pulse. It's kind of like a really slap slap in the face of myeloma once a week. Sometimes that dex, so that steroid, is too much for people, and we've historically gone to a much lower dose and give it every other day. Maybe you and I could chat after a little bit more about that, because I don't want to question someone from the stage, but that's not a strategy we typically use a lot in maintenance anymore, to continue steroids. If anything, we tend to want to not give steroids. I have seen steroids themselves, by the way, cause styes. So I may want to minimize steroids in your situation, but maybe we could discuss a little bit more at the break.
All right. Yeah, we can take 2 more questions. If there's one more question over there.
Why do they wait until you took some fairly dramatic drugs to collect your stem cells? Why not get them before that? It just doesn't.
Sorry, did you ask why do we give that induction treatment before collecting the stem cells?
Sure,
as opposed to just collecting them off the start?
Good.
Right, great question. So the reality is these stem cells in your marrow are surrounded by myeloma. And we have tried exactly that thing. It is very hard to collect good stem cells when someone has a marrow full of myeloma, even if it's not full, like 10, 20, 30%. The thing with myeloma that is weird is that, you don't go to another patient and say, well, how many plasma cells did you have in your bone marrow? Like, I had 20% and I heard he had 40%. Again, I'm not trying to make light of it, but it's not, that absolute percentage doesn't mean that 40% is twice as bad as 20%. Myeloma is evil, and even small percentage of it can really invade and overtake the bone marrow. So it is not going to let those stem cells get out easily. So that's why we've learned that the collecting of stem cells, let alone the benefit of transplant, is had when someone's disease has dropped at least by 50%, if not 90%.
One more question.
Hi. What is your opinion of the new PEMGARDA, especially because the new COVID vaccine is not available? I know it's not readily available at all centers, but would that be something that you recommend?
Does anybody else want to take that? I feel like I'm taking every question here.
I don't want to take that one. I just, yeah.
Yeah, I think it's just a little bit early yet. Like, so let me back up for just a minute. Because we're always try to find this balance. And you probably saw from our blog last week, that COVID, there's been a bit of a summer surge in certain places. We don't want to make it sound that myeloma patients are so at risk of COVID or other, community-acquired infections that, you're going to get it tomorrow by noon and you're going to be sick and be horribly sick with it. On the other hand, we also want to encourage people that vaccinations have clearly demonstrated tremendous benefit in all patients. Cancer, non-cancer. Cancer on therapy, not on therapy. I mean, it's very, very clear that there are benefits. Obviously, it has to be discussed individually. There are a whole series of products now that are being developed to help protect people, either because they can't get a vaccination or it's anticipated that they're not going to have as robust a response to vaccination. The reality is we just don't have a lot of evidence for it, right? I've always tried to think of whether it's COVID or any of these infections. I mean, long before anybody got excited about masks, we were talking about masks after transplant. For those of you who've had a transplant before COVID, you're familiar with this, right? We had the whole discussion about the hand washing, social distancing, hand sanitizer, masks. Those weren't new when COVID happened. We had been doing those. And I try to think of it as sort of a multi-hit phenomenon, that we want as many layers of protection as possible when we're at greatest risk. So I think I would stay tuned to the IMF website, because we do try and comment on these things. I think the evidence is emerging. I think, in short, I would encourage people to keep up with their vaccinations, to talk to their both oncologists and their primary care, because sometimes we as oncologists think that the primary care is taking care of it. The primary care thinks that we're taking care of it, so that the ball can get dropped. And to keep up on, the FDA actually has been quite good, and the CDC and their guidelines on the websites. That's how most of us have kept informed.
So we'll have more panel questions tomorrow. I want to say 2 things before I invite Robin to close us for this afternoon. Daniel, Robin, Dr. Joe, Teresa, Wendy, thank you for your presentation. and being on the panel. And I also want to tell you that whether you are here after a couple of months of your diagnosis, you are here because you have a broken back, you are here having supported the IMF for many years after losing your loved ones, or you are really doing well and living, thriving with myeloma. Thank you for being here, and welcome to the Los Angeles Patient and Family Seminar.